You're listening to the Not Your Lawyer podcast with Mona Reza.
Hello and welcome. I'm so happy to have you on with me.
Thanks. I am so excited to be here.
Everyone, this is one of my very favorite people. Sometimes in life, you meet somebody and you just know we hit it off immediately. And our first interactions, Dr. Ogo graciously invited me to come and speak at a conference she put on at National Harbor. And I was blown away, both by the content and also the attendance. Because if any of you work in communities where people want buy-in from physicians and healthcare providers, or if you are a physician and healthcare provider who knows how valuable your time is, the complaint is always, well, they're never in the room. They're never part of the conversation. I will tell you, every seat was full in that room, and the sponsorships were from every swath of industry that touches healthcare, from the comptroller's office to the big insurance companies, HBCUs, everyone was represented. So, Ogo, could you tell the audience a little bit about Career Haven and what you did with that program? And I know you've made a little bit of a pivot, but what got you into this space?
Great question. I think to fully answer the question, I have to take you into my history. For those who know me well, so I'm Ogo Ekwueme. I am director here at Career Haven. Career Haven is a innovation engine. Our job is to partner with clinicians, health coaches, consultants, and community impact organizations to get them linked with funders who want to fund impact. They see you guys as the experts and they want to give you the money. The problem is you're not in the room. We're having conversations and we're always talking about, where are the clinicians? My job is to get you guys in the room because they are ready to put dollars behind you. I started in just healthcare in general. For as long as I can remember, I was supposed to be a doctor. I have a Nigerian background, so I only had two options in life. You're either going to be a doctor or you're going to be a nurse. Pick. But it was going to be something in the medical field. And so I was on the doctor route for a long time. And I think a lot of us, we follow blindly because we feel like it's just the right thing to do. But you get to a crossroad and you're like, well, what do I really want to make out of this? And when I was in undergrad transitioning to grad school, that was the crux for me. Like, what am I really doing? Am I really making impact, or am I just following orders? And so I said, you know what? I'm going to take a short stint in grad school. And if my love for medicine keeps pulling me, I'm going to go to med school. The love for medicine didn't pull me. And I didn't go to med school. But I did stay in medicine, and I found a space that fits who I am better, which is the integration of systems engineering, medical knowledge, as well as technology. Then I segued into direct government contracting, which is partnering with government entities to provide healthcare services. A lot of people, when they think about healthcare services, they're only thinking about, okay, I need to open a practice. I need to become billable. I need to do authorizations with insurance companies, that type of process, very narrow-minded focus. But no, there's a whole entire lane called the community impact space. In this space, you're being paid for community level results, not individual level results, community level results. We go back to the sciences real quick and we talk about, okay, what determines the health outcome of an individual? Yes, it's my life choices, but it's also the structural items around me, what I have access to, where I live, the cleanliness of the air around me, whether my neighbor is dumping toxic waste into the pond behind my house. There's those structural environmental elements also feed into the health of our community. I have an MPH in public health. And so these are the systems level thinking we've been accustomed to looking at. And I now think about the money. Government will pay you to take what you're doing for one client, one consultation, one 15-minute session, which I think is the hallmark productivity marker. Like, how many patients can we see in 15-minute increments? Instead of you doing that all day, every day, and burning out, the government would say, okay, for $50,000, how many people do you think you can get into a workshop? And potentially that workshop is once a month, where you as the clinician, the educator, can now step in, give the same education, a one-to-many format, and they cut you a check for $50,000. They cut you a check for $100,000. That check then covers a substantial portion of your salary, covers some of your overhead, covers some of the travel to get to the workshop, covers the venue of the workshop, but you've just condensed 30 days of 15-minute services to 100 patients into a 1 to 2 hour workshop for the same amount of revenue.
And I would argue you're making more impact because each person in that room gets the value of that 1 to 2 hour workshop in a way that you just cannot. Despite their best efforts, you just can't get that in your quick doctor's visit.
You can't. You cannot. I think the clinical setting has its space where I need to have a private conversation. I don't want to tell my business to the world. But so much of what we do in those one-to-one interactions can be scaled to a one-to-many model where insurance may not pay for that. But there's another side to that insurance company called the community impact side where they will pay for that. Let me give you a case in point. I am very, very good friends with a lot of high-level VPs, executives at Care First Blue Cross Blue Shield, one of the major payers in our area. Yes, on the provider end, they are compensating you for seeing their client in a 15-minute, 20-minute interaction. If you just stopped talking to provider services and went over to the community impact division and talked to their community impact manager and said, I want to educate 100 people on this topic that is a high priority for you because you guys keep telling me that you need to lower the risk markers in this particular domain. I'm going to do these workshops. I, as a clinician, an expert, that everyone keeps saying that we are a hot commodity right now because I am a limited resource. I'm going to make myself available for these workshops once a month. If you give me an additional $100,000 that is not attached to the number of people I see, that is not attached to the number of hours I work in my clinic, that is not attached to billing codes, to CPT codes, etc. And we're not going back and forth about whether it's clinically justified. They will give you that check.
And this matters, especially, providers here in Maryland, in our Washington metropolitan area, listen carefully. And it's so sad, and I hope that even if you listen to 15 minutes of this conversation, you realize it, because Ogo and I know my husband is gastroenterologist. He's an excellent gastroenterologist leaving this area because one of the ironies of it is the reimbursements on the provider side, Care First, Medicare, Medicaid, everybody, it's lower than it is in other parts of the country for the exact same procedure. But you all know our cost of living is higher. Employment laws are meant to protect our employees. For small business owners, it's shutting them down. And that all kind of trickles through to the patient and the care you're going to get, because in order to keep the lights on, your doctor is seeing 20 patients a day. And that doesn't leave time to do anything. It doesn't leave time to explore ancillary services, joint ventures, things like what Dr. Ogo is describing that could really make a difference, right? And we met because part of trying to keep this solo practice going was you look at the numbers and you say, these insurance reimbursements are not going to keep the doors open. What do? You take venture capital funding, you join a hospital group. There's all these options that may or may not be a good fit for every physician. And I'm not going to say whether it's good for patients or not. You tell me, how great is your experience when you're in one of those groups? And then you have this alternative where, as a physician, you can build in ancillaries. You can do clinical trials. You can add some aesthetics. You can do things like that that will then bring money into your practice, so you don't have to ask people what kind of insurance do you have or cut certain insurances. You're able to really treat your community. So I think the challenge is getting the providers to take a breath and say, hey, you invest this much time in doing this, and you will be able to keep doing what you went to med school to do. So how much of a time investment is it for the provider themselves, Ogo? Say they want to work with you. What does that involve?
Actually, it's very minimal. What we've pivoted into is a 100% done for you model, because we recognize the times. We recognize that a lot of people are busy with what's happening right now politically. There's a lot changing in the reimbursement landscape, and a lot of practices are having to figure out what to do. So for us, we're like, okay, how do we get you into these rooms quicker with the least amount of resistance? And so we offer what we call a 90-day funding package, where we essentially build out an entire program structure for you. We take what you're doing in your clinical services and we package a community-based program. with everything funders would want to see. Let me be honest. We've done the teaching model where we try to teach it and have people do for themselves. We run into the barriers of people are just busy because it's like a wheel. We're in this wheel. We're spinning. You really don't have much time for anything else, even though you know it is good for you and it is the next natural step to expand your services. But time is a commodity. Time is limited. So we're like, you know what? Let's get out of teaching and let's do it. We're in this space. We have these conversations every single day. I'm in rooms with funders, with local stakeholders, with senators, congressmen, council members, etc. We're having these conversations all the time where I can take our industry knowledge, take your clinical services, mesh it into what I know they need to see, show you exactly who you need to talk to, who's looking for what it is that you offer, and how to get in contact with them. The only investment we tell our clinical clients is who's going to talk to the funders on behalf of your organization. And most times you already have someone on staff that you are paying a full-time salary to talk, to get on phones, to make those relationships in the community. Would it not serve you better to have that individual become a revenue generating position where they can now call these funders with the scripts we've already provided, with everything that you need in order to showcase your value to them? And now they can open the door to these conversations. They can open the door to new funding avenues. They can open the door to another 6-figure check that subsidizes your practice, but doesn't rely on you working more every day.
Absolutely. And I think one of the discussions you and I had when we come to this, there's two main things. There's Stark and there's anti-kickback, right? Stark applies only to physicians. Anti-kickback applies to anyone getting federal funding for healthcare. And so as you structure it, you have to be very careful not to run afoul of any of those things. And often these barriers to entry for people is being so focused on what you know and what you do that you're almost afraid of the unknown. And so even something as simple as that, like I would say, I would advise anybody that's doing this, have a separate LLC for your consulting, for your business part. Don't bring that through your medical practice. You can absolutely use it to fund some services. You can pay that person in your office who is taking those calls a separate payment. They can be a consultant. You can pay them a salary, whatever that categorization that's right for your business from what you're getting from that side. But keep it clean, keep it separate, because there's that fear in the medical industry, and rightfully, very few industries are regulated in the same way. What started out with good intent to protect patients really handcuffs practitioners, particularly in our area, things like certificates of need. The idea that there can't be any financial incentive tied to the patient care. So you can't pay per referral. And there's good reason for that, but it's also important to keep it clean and separate, because when you're doing this, essentially it's a separate business, right? Like a consulting business. And so I know a lot of doctors who they look on Instagram or TikTok and they're like, not one of those doctors. Especially in a certain generation, it's a point of pride that I'm not out there. I would say the other side of that is those physicians are doing a service. They are one to many. They're giving people advice. They're giving them information. And what you're providing is that middle ground. You don't have to be a TikTok doctor, but you can be a consultant, a provider, a speaker who's getting out there, getting that same federal funding that you have worked for. Believe me, when you're getting a check for 80 cents for that liability that you put into seeing every patient, the care you put, the sleepless nights, it's downright insulting. So if you can go back and you can give people the tools they need to be healthy and to understand some of the underlying causes of their disease and get Care First to pay for it, or one of these other providers that are shortchanging you on the provider side, I think it's win-win.
It is. It is. I think between our organizations, Mona, I think we need to explore a combination package for doctors and clinical providers where they get the legal guidance and structuring as well as the support in actually pulling the funding in. Because I think they go hand in hand. As you said, yes, you want to be strategic in how you plan the execution. Even with the TikTok doctors or the social media influencers, if you notice that in their In their bios, you're starting to see a lot of them say this is not medical advice, that please see your primary care practitioner, because they are also getting into the ring of regulation. And it's not an unregulated space, but is a space that can serve you very well if you just understand the rules and the way it's structured. And I tell everybody, you know, even some of the most famous organizations that you know of and you envy, like Mayo Clinic. Mayo Clinic brings in billions of dollars of funding that is not attached to clinical care, that is not attached to fundraising, like, you know, individual donations. It's funding dollars that come from entities that they showcase that they are doing community level programming. They are impacting the community in a systemic way, not just an individual way. And they are bringing in dollars through that channel. And to me, it's like, don't replicate the wheel. If it's working for the larger entities, that tells us something. It's a hallmark sign that, okay, this kind of structure works. It makes sense. It builds sustainability. It unhinges your impact from one-on-one interactions and gives you something more substantial to leverage. And I had this conversation yesterday when I was at the county office. I'm talking about what the needs are in our community. And I said, if the larger hospitals who are running on razor thin margins can't do community impact programming, then let the smaller clinical practices leverage your name, leverage your brand presence, leverage a partnership with you to pull in funding where they could be your execution arm. $100,000 to a smaller clinical practice goes so much further than $100,000 for a multi-site hospital system. And therein lies a mutually beneficial relationship, partnership that brings in impact and still serves the community. I can't emphasize it more that the structure of how you do this is going to be key between how you get the funding and how you structure how the funding flows through your entities. I know Mona is really, really great at looking at both sides and understanding both sides. So I think we need to do something like that.
It's a misconception that physicians have all of this disposable income. I think that they make a good living, certainly, right? But it's not the 80s anymore. And so in many ways, they have risk, they have liability, they have enough income to be dangerous, but they're very hesitant to invest that money in protecting themselves in the way that they need to be protected. And they're not the only ones. There's a lot of people out there. I think entrepreneurs like us, people who are entrepreneurial, whether it's a physician or, you know, anybody else, we understand that the fastest way to get somewhere is having experts help you do the parts that you don't know about so that you can really soar. And so one of the things we've done is created our subscription services. And absolutely, I think that I would love to work on something with you to get something really tailored to healthcare businesses who are in this model. Because like you were saying, especially if it's something repeatable, it can be offered at a lower price point. And it can be done in a way that we know that you are protected. We are familiar with these contracts. We know what to look for. We know what to take out. I've seen contracts. You would just be shocked at some of the things that have come across my desk that my husband has been asked to sign because they assume that the physician is not going to pay to have someone look over this contract. Or the person on the other side may be a health law attorney, possibly. They may be general counsel. But what they're not is a tax attorney. And what they are not is sometimes a health law attorney. So they don't understand that intersection between there are things you can't promise. And so those words, that jumble of words, it means something. And you should understand what it means. And that is, I think, for both of us, our goal is we'll do as much of it for you as we can. But part of what we're going to do for you is make sure you understand what you're signing and what you're agreeing to do.
It also goes back to, you know, medicine isn't what it used to be or what we thought it would be. And especially for the younger generation or the newer generation of doctors, because I work with all levels and, you know, they're looking for more balance. They're looking for a better lifestyle. They're looking for ways in which they're still able to achieve what they came into medicine for without the burnout, without the exhaustion, without the long hours. And I tell them, well, start building this in a new way. Start leveraging what is available. Start asking yourself, okay, these larger practices, these larger businesses and organizations, Are they running themselves to the ground like I am running myself? Or are they structured in a different manner? And Mona, these larger hospital systems, they've got things compartmentalized, different service lines are coming through different avenues. Like everything is very well thought out, but it ultimately builds a sustainability that all clinicians should strive for.
And I would say, Ogo, like one of the things that I tell my healthcare provider clients is it is not you, it's the system.
Yeah.
Because while they have all of that, they also make about 4 times more than you do for the exact same procedure at the hospital. That's how the system is rigged against smaller practices. I'm not going to pick on my home state. I love Maryland, but as we've expanded out and looked at other places, there are differences. You can go somewhere that doesn't have a certificate of need and you can run your ambulatory center and not have to worry about the hospital down the street fighting back and saying, oh, no, they don't need that, so that they don't have a competitor.
Mm-hmm.
And so at the end of the day, patients should care because this impacts you. You know, it happened to me. I had a colonoscopy. I always had it at my husband's center and it was fine. I'm in a different position in many ways, but still I get the bill for anesthesia and different things. I had it done at a hospital once because it was a next level situation. And the care wasn't better. The rooms weren't better, but the bill was like 6 times higher because it was done in a hospital setting versus an ambulatory center. Yeah. It is in everybody's best interest, if you qualify to have your procedure done at an ambulatory center, to have it done there. It's going to be cheaper for you, the patient. Yeah. But for the physician, they're going to get a fraction of what they would have gotten if they were employed by the hospital, doing it at the hospital. The misconception people who have their heads down working hard that they have is, I did something wrong. Why am I like working until 9 o'clock at night and not able to do what this hospital is doing down the street?
Yeah, it's the structure. It's the structure. Yeah. And I was very candid in the meetings that I've been in lately. And I said, you know, the clinical practices, the independent practices, the physicians, they want to do more. It's not for lack of passion for the community. It's not for lack of wanting to be helpful and useful. It's the structure. They step into these lanes. They realize, okay, I'm not just competing with my fellow colleague. I'm competing with the hospital down the road. And let's be honest, on paper, that hospital will always look better than I will. And so we've got to restructure how we see the system. But there's 2 sides. There's policy where, you know, me and my policy people, we're working on that. That's not an overnight shift. But in the meantime, maximize what you do have, what we know currently does exist. And that's where this lane becomes so pivotal for them to maximize is, okay, if I know, and I think the number is about 147 billion annually that goes through this lane where it can be directed towards community-based programming. Clinical-based services that serve one-to-many on a community level. That's the magnitude of what we're talking about. That does not require reimbursement, CPT codes, all of the things that we are used to. Now, if all you did was invest in getting yourself packaged and structured to now work in this lane where you're still billing, so it's not that revenue stops coming in, it's now giving myself a second channel to compound my efforts. And that's the way we want them to start thinking about that. This is a channel to expand what you are already doing. And for some, what they will realize quickly, it reduces their workload. It reduces the amount of time they have to spend one-to-one and gives them breathing room to say, okay, well, I can go on vacation this month. I can take off 2 months in the year because I did a couple workshops and we've got enough revenue to keep us going.
Or to even hire, right? Because it's hard.
Or hire another individual. Yeah.
This younger generation, and God bless them, you know, in every industry, they just do not do what we used to do. They don't put up with it. And part of that is they don't want to work in small practices. They want venture capital funding. They want big hospital. They want to be somewhere in a sexier city, all of it. And good for them. But our communities need physicians in our community. And in order to attract them, we have to be able to give them something different. You can't say, hey, you want to work till 80 like I had to just to kind of get through the day. Nobody wants that life. Nobody's going to look at you and be like, hey, I want this. And so if we give them opportunities to be creative, to run these workshops, let's do an example, Ogo, like for pick a practice area for gastroenterology.
Okay.
Right? One of the thoughts I had early on, I listened, the walls are thin, I can hear the advice, cut dairy, eat this, the simple advice of what can make your systems run better and help you deal with your disease. And I always thought, wouldn't it be great if we could do like a session with a nutritionist and have the doctor come in and really talk about not just weight loss, but living well and how to do it in an affordable way, because everybody can't have a private chef and everybody can't shop at Whole Foods. How do we do this in a way that is not overwhelming for patients? How could you work something like that into a funding program? Or could you?
How long do we have? Because this is my bread and butter. Okay, so number one, we call this captive audience theory, where we're going to hedge the ultimate goal to what is a main driver for the community. And this is something unique that when you show funders this, they're like, okay, you've got a grasp on your community that we don't have. Remember, funders, more often than not, they are in an office. They are doing paperwork. They may come in the community sporadically, but they leverage partners like clinicians to be the go-to in the community. Let that set the baseline. So now you present to them, I know how to improve GI outcomes. Right now, colorectal cancer is a hot topic. The levels of younger individuals being diagnosed are increasing. And we know a lot of that is lifestyle. But are you going to get every person in your locality into your office to talk to them for 15 minutes about the things that put them at risk for colorectal cancer? No, it's not possible. You'll go crazy trying to do that. Versus if you said, we want to run a program that is going to create awareness of the rising colorectal cancer rates, especially among those ages 30 to 55. We're going to center it on something that captures their attention immediately. So assuming you said, okay, my target population is women, middle-aged women. What is something that middle-aged women think about? It motivates them, it pushes them, it drives them.
Oh, I know.
First thought in my mind, fashion. Let's do something that integrates fashion. The other thought in my mind is this is usually the age group where metabolism starts to slope.
Yeah.
We start putting on a little bit more weight and we start hitting the gym, or we start comparing. We're like, oh, the jeans don't fit like they used to. Imagine you did workshops on how to redefine your body image, how to lose the weight, take the pounds off, and feel like your best self.
Yeah.
The language you're using now, it's not clinical speak. And that's what we help clinicians understand.
Right.
We know the clinical speak works for clinical documentation. On the community level, it's a different set of languages. What is it the audience wants to see? Now, I can get you into a room where I'm talking about you fitting those jeans, the dresses, you want to look good like your best self after 40. That's going to attract you. What else am I going to talk about while you're there? Well, while we're talking about shaving the pounds down, sis, how much poop is still sitting in your rectum? Very vivid, very, very vivid. But it gets them thinking. I came in to lose weight. I came in to look good. But I got a lesson about backed up poop in my system that not only is making me feel heavy and bloated, it's increasing my risk for cancer. If I am not going to the bathroom frequently enough on a daily basis or whatever rhythm my body works at, I'm at increased risk. If I am eating the foods that are backing up my system, not only am I putting the pounds on, I'm increasing the risk of colorectal cancer. So I'm taking your audience capture from what they want to see into what we as clinicians need to teach them. I show the funder that this is the structure of how this program will flow, how I'm going to bring the women in, how we're going to execute, who's going to teach, who's going to train, what are we going to measure. In a workshop style, we like to measure change in understanding, and you can do that easily with surveys. What did you understand now more about colorectal risk that you didn't understand when you came in? And as long as your audience is telling you, oh, now I see that the things I'm doing have been putting me more at risk. Did you enjoy the workshop? Would you come back? These are measures of success, not just billable codes. How do I justify the billing? It's a different line of thought, but it's almost a simpler way to think about medicine.
Yeah.
It's almost like, how do I take the social media brain and turn it into a program where I just go straight to the community, who I want to serve, who I want to see, who I want to educate. And now it's one to many, 100 women in the room. We laughed. We talked about looking good. We talked about something that made them feel happy. We talked about the science. We made it relevant. And that funder can now hand me $50,000 versus me being in the clinic every day for a whole month to try to make the same in revenue and fight the insurance for the reimbursement.
But do they require you to have a clinic? Like, so say there's a practitioner who wants to make this their business. You're trained. Many of the women I've met who have left traditional practice, it's been because of something really serious, like a sick child, or they have an illness themselves. And so you've got this skill set and you love treating people, but you cannot run a clinic. Is a requirement that you have to currently be running a clinic? Or can you come in and say, hey, I am, a derm. I'm a dermatologist. I'm trained. I'm board certified, all of it. I don't currently run a clinic. Or I'm not licensed in this state, but here's where they really need my help. I have the separate LLC where I consult. Would they pay somebody like that to go and be a speaker in different communities? Or do you have to have a clinic and be running it in the state that you're speaking in?
No, it's not a requirement. There are some services where they are intent. They want to see, okay, after you educate, like in maternal health, for example, maternal health, what we're seeing a pattern of is funders asking for you to, after educating mothers, referring them to get prenatal care. They want to see the community clinical connection.
Yeah.
In that regard, we want to show that. But many programs don't actually require there to be a clinic involved. What they really ultimately want is the clinician to be an engaged party at a level that I don't want to say very rarely seen, but not seen enough. The clinicians are so busy in the clinics that we don't have enough doing the community level work. What they want to see is more in the community. So if we have clinicians that are retired, who had to step away from clinical practice, or maybe they're taking a break, this is a great way to now reposition them to be a community influence, to be a community impact engine, but not be tied to one-on-one clinical based services.
Yeah.
So those who are still in practice can do a combination of both and build a more balanced practice and lifestyle. Those who are out of clinical practice can still leverage those skills, their passion for educating, their passion for medicine in a space where they are going to be highly valued. And one of the beautiful things, Mona, is even if I am not licensed in the state where I currently find myself in, it's not necessarily just a license they look at. It is the person, the clinician, your knowledge base, what you bring to the table, your resume, your years of study, your years of education, the things that are so valuable to them. Where we've overemphasized the licensing is the one-on-one clinical billable services, where that is a main requirement. But in this space, it's not. I have had clinicians as educators in workshops for diabetes who were out of state, but the workshop took place here in the state of Maryland.
Ooh, Ogo, I have an idea. What if we brought Dr. Din back as an educator? We would be the heroes of the Greenbelt community.
Yes. Yes. We need to do that.
And
yes.
I did negotiate that exception for him, that he is able to do things that are not a direct competition. So he absolutely could do something like that. Will he do it? I don't know. It's very hard to get him to do ancillary things. But for me, with our law firm, one of the gaps that I identified from the employment side is that we have this brain drain of women who've had to put their careers to the side to raise their families or step in an emergency, and building a system where we value that and we raise that up and we're able to build equity while you're doing that, so that when you are ready to go, you haven't lost years of investing in the practice of law. What you're describing, there's an entire group of women who have had to off-ramp from medicine for the same reason.
Oh, wow.
No matter what your spouse does, if your mom is what I've seen, it's usually mom who has to take that break from the practice of medicine to step away and take care of whatever the family emergency is.
Yeah.
This could be a really wonderful way for practitioners like that who care deeply about their patients and their communities. I'd say they're better suited than somebody who's working an 80-hour week to really build materials and come in and speak and impact communities all over the country.
Yeah. And you don't have to do it alone, Mona. I think the other thing is making sure we understand that collaboration is key. You don't have to build the program alone. You don't have to do this by yourself. You don't have to figure it out by yourself. And even once the funder gives you the money, you don't have to execute by yourself. There are other organizations who will partner, who want to be a part of what you're doing. They don't have clinical person on staff. So if they saw a clinical person available to be part of a program, it's a win-win all over the board, and the community wins as well. So there is so much that can be done. I would say the biggest thing or the biggest limitation is just as clinicians, as consultants, thinking outside the box. The past year, a year and a half has challenged us in medicine. Like, how are we really serving? How are we serving the people that need us most? And as we prepare for the healthcare landscape to drastically change again, how will we be of service where it's most impactful and we still build thriving businesses in the process?
Absolutely. And this is such a great on-ramp. What we've learned is that nothing is guaranteed. If this funding goes away, but you've had this on-ramp to build your reputation, your brand, your community, well, now you can take that and build something else out of it that doesn't require funding.
Exactly. Because once you've captured the trust of the community, it's yours. And what we have seen is these funders will continue to work with you year in, year over, because you are the entity of trust. You are the influencer, if I could use that phrase. You are the influencer in real life, not just in social media speak. Even those that have practices, if you educate me on colorectal cancer, if I am having issues with my GI tract in any way, shape, or form, whose practice do you think I'm going to be looking for after that workshop?
Absolutely.
Yours.
Beyond the money, beyond the opportunity, it's such a dire need. I will tell you, and I think I've told you this before, that I went to a very small high school. I went to Regina High School, and I had a classmate and dear friend whose birthday was the day before mine. And I actually introduced her to her husband. He was one of my best friends, and they got married. They were married for years and years. And she wasn't feeling well, probably in her 40s. And, you know, we're baseline. We don't feel well. We're moms. We just keep moving. And by the time they diagnosed her colon cancer, it was too late. You know, she passed away before we were 50, before the year that you're supposed to be diagnosed. She had passed away. And for me, when I was 36, I had some discomfort, something that seemed wrong. And because my husband's a gastroenterologist, that's always the first thing, is go and get a colonoscopy. And I did. And it got me on this regimen of colonoscopies because they did find something. I can't imagine that if something was there from when I was 36 to when I was 50, that I would have made it to 50. And so, you know, I always think of Rosa when I think of that disparity. Because back then, like now it's 45. Back then, insurance wasn't even covering colonoscopies before 50. So, you know, you're jumping through hoops to try and get the treatment you need. And if there's any way that you can just push it down and say, no, I'm fine, you're going to do it. But if you're sitting in a group, in a room full of people who are similarly situated, and you've got a provider right there, and you're listening to this information and you're processing it because you have the time and the space to do it, that hopefully it also will ring some bells for people that this is more serious than just a stomach ache or constipation or whatever it is. I need to get this looked at. You have the strength to advocate for yourself, right? For hormone replacement therapy. I was speaking on a panel on midlife wealth at a midlife health conference, and I listened to all of these practitioners talking about these different things. And I was, you know, felt terrible. I'm there and I'm feeling awful, but I'm just pushing through because that's what we do. And you feel empowered with that information to go back to your practitioners who can only see you for 15 minutes at a time and say, okay, yes, I am 50, whatever, but I need you to fix this. I'm not going to just feel like this. I need something to resolve this. Right. And I think that's a huge, beyond money, it's a huge service for the community.
Yeah. Agreed.
So how does somebody work with you? What do they do to work with you?
They can send us an email, support@careerhaven.com, and we can schedule time to talk about what it is that they are doing in clinical practice. They can attend one of our live webinars by registering at careerhaven.com. We try to do them every 2 or so weeks where we can bring a large audience of people and talk to everyone at the same time and answer questions. But they can also reach out to me at support@careerhaven.com, and then we can talk about their options and see where they are in practice and where they want to go.
Okay, great. And we're going to throw all your information up in the show notes as well. I encourage anyone, if you think that this is something that might be for you, Ogo is the real deal. I've worked with her for a long time now, and it is rare to see someone who just gets it done. And so I'm so excited for this new iteration of Career Haven that I think has been in the making. And I think it's going to be really beyond impactful. It's what we need in our area, but I think all over our country.
Yeah. Agreed. But you and I need to sit down and talk about this combination package.
Absolutely.
Sounds like the natural next step.
Absolutely. Well, thank you so much for joining me. And I look forward to seeing what's next.
You're listening to the Not Your Lawyer podcast with Mona Reza.